Unmute myself. All right. Well, good afternoon, everybody. I hope everyone can hear me okay. We are going to go ahead and get started. I see there's quite a few people have joined already. So thanks for joining us this afternoon. Just for housekeeping issues here, we are just with the whole Zoom thing, we've learned it seems better to keep other participants on mute while we're just doing the initial talk part. And what we'll do is if questions come up during the talk, if you see the little chat window there, if you can enter any questions that may come to mind in there, we'll keep an eye on that and try to get to those at the end. What we'll be talking about today is this Cleerly Health technology that we have started to use to help with our identification of people with heart disease, and it's an imaging tool that supplements cardiac CTA in terms of trying to get a diagnosis of coronary artery disease. So the idea of this talk is to kind of give a little bit of a little bit of background to the problem at hand. What is it that this type of testing is ideal for? Who might be the type of person who would want to get this type of test done? What the utility of it is, and how best to use that to sort of manage patients. So really the size and the scope of and the cost of the problem is really one of the first things to sort of highlight, to put this particular imaging modality and this type of testing in perspective. Let's see if I can get my slides to work first. All right, here we go. So we know that heart disease, we always hear in the news of people who unexpectedly die of a heart attack, or that this person who had no real warning sign had a heart attack, and things like that. We know several things about coronary artery disease death phenomenon, and we know that several things are that the rate of it is reasonably unchanged. The number of people who have this hasn't really diminished all that much, and it does account still for 1 out of every 4 deaths. It many times happen in people who are apparently at low risk at the first time of their heart attack, and this slide there shows a fellow called Bob Harper from The Big Loser, the Biggest Loser, who died but was resuscitated while working out at the gym. It is often silent, and that the first warning sign of them having a problem is that they, and more than half the time, is the actual acute cardiac event that came out of the blue. One of the CEO of United Airlines had a sudden heart attack a month after starting his job there. A lot of the blockages that cause heart attacks, people have the mistaken idea sometimes that heart attacks happen when a blockage in the artery gradually gets worse and worse over time, and all of a sudden becomes occluded and things like that. But we know that a lot of heart attack type blockages come from plaque that was relatively mild looking in terms of its impact on the blood vessel, but became unstable and suddenly changed and occluded. And so there's poor Tom Russert from Meet the Press died not long after a normal stress test. And I think a lot of people have heard of people who've said, oh, well, their stress test was normal, but they still had a heart attack not long after. I think that's because stress tests are only become abnormal when you've already got at least a 70% blockage typically. So there's ways that you can still have a heart attack after a normal stress test. Oftentimes this happens in young people. So this does affect young folks as well. Unfortunately, we have a little bit of a misconception that it only happens to old people, but that's not entirely true. Yes, heart disease does become more common with age, but this is happening in young folks too. So we have this kind of idea that knowing all these little pieces of information, we sort of believe that a large number of heart attacks are potentially preventable. But the holy grail of all of this is trying to find what method would we use to try and identify that person who is at risk. Certainly not everybody is, but there are some people who perhaps they have things about them that we could identify early and then try and do something to intervene on that before it becomes a much more grave problem. Again, for things to be put into perspective here, this is just data that I just acquired really quite recently, was looking at mortality statistics. And I think we can go back and look at total number of deaths. There are about 3 million deaths in the United States every year. And heart disease always ranks as number one. So that's one big telltale feature there, that it's still the number one cause of death. And we have not really made big inroads into that number in terms of getting it to trend downwards as a percentage of the total. Cancer is usually number two on that list, coming slightly in behind all of that. If we drop down a few lines there, stroke is not too far behind, and that shares a lot of similar properties with coronary artery disease and heart attack risks. So I think, things related to heart and vascular disease account for a large number of deaths. But an interesting statistic there is that in 2020, obviously COVID made an appearance on the scene as a new category and came in with 345,000 deaths in 2020, obviously a very large number and a number we wish was not there. I think, and if one thing I just kind of noticed about that was that the number of deaths from heart disease is still above that. It is in fact twice as high of a number as the number of deaths from COVID. And if we stop for a minute and think how much all of our lives have been impacted by some of the things we've tried to do to mitigate COVID-19, or the things we've tried to do to really get on top of that and make those excess deaths go away, from the social distancing to vaccine programs and all the different things that we have brought in to try and get that under control. Still, coronary artery disease is double that. So I guess I would, field a call to try and get some, it would be worthwhile for us to take a solid look at this heart disease thing and not just treat it as, oh, that's just another number, that always happens, let's not worry about it. I think we should at least try and be prepared to make, an effort to get that number down that's in proportion to the amount of trouble that causes in our society. So moving on. The heart disease cost and burden is a huge number. This costs a lot in terms of the lost productivity, the amount of money that's spent on the healthcare for these people, a lot of work days missed for each patient that has this happen. So it's a very costly problem. And I think the comment here is that our prevention system is broken and expensive. We spend a lot of money on it. We don't seem to really get much out of trying to prevent it at the moment. So what we need is innovative things that can identify the actual disease, not just listen for symptoms that may not be there until it's too late, or try and find some sort of surrogate for the disease, but actually see the disease itself. So this slide here just kind of gives us a little bit of a pictorial, I think, for people who really haven't kind of had a chance to look at pictures of coronaries and understand what do we mean by plaque, what do we mean by coronary heart disease or coronary artery disease. Those are all sort of synonyms that we use to describe the same thing. So the fancy medical name for this, or coronary artery disease or plaque, is atherosclerosis, and that's the buildup of fatty material, at least initially, in the wall of the coronary artery. Coronary arteries, whose job it is to get the heart all the blood flow and oxygen that it needs to work as a muscular pump. And as those plaques build up over time, one of the things that can happen is, if we see over in this picture here, this plaque, which doesn't really obstruct the blockage in and of itself here, it doesn't obstruct the artery in and of itself by a large degree. If it were to become unstable and the cap of that plaque would rupture, a clot can form on top of there, which can really obstruct the blood vessel. And then once you've got an obstruction to the blood flow in that vessel, that's when you start to have a cardiac event, so to speak, or an acute coronary syndrome, or in other words, a heart attack. So those are all sort of words that we use to throw around. So just to give you an idea of what it is we're looking for. So that, the plaque over in the coronary artery, is what we would like to be able to image in some fashion to be able to see what's there. So let's see if I can make this work. So with CT technology, we can combine the utility of coronary CTA scanning with some advanced imaging that helps us really get down to the nitty-gritty of what's going on. So this graphic here shows you quite nicely in a sort of three-dimensional way what a CT is able to, sorry, let me go back to that, what a CT scan is able to accomplish. We inject a little bit of contrast into the person's IV. That contrast then goes to the heart. If we use special software to help make sure that we get the imaging done at a point in the cardiac cycle where the heart is relatively still and motion free. And our hope then is we get these nice images of the coronary arteries. It's a non-invasive technique, so that has an advantage for people who maybe we want to just do something to figure them out without exposing them to the risk of an invasive catheterization procedure. We have really started to use this more and more to help us with that, because the technology is getting to the point where the imaging is very, very good. And the idea is that the type of plaque that's there is a very important phenomenon. And this is kind of, I'll sort of orientate you to the screen a little bit. Basically, the worst types of plaque are over here on the left side of the screen. Those are the ones that are most at risk for causing problems. And the ones on the right-hand side of the screen are more benign, and they don't cause as much problem. These images are all cross-sectional images. If you were to think back to that three-dimensional picture of coronaries, we're able to use the CT scanner to actually create lots of different ways of looking at these things, but one way to look at them is in cross sections. And each of these screens here, they've shown you the a little yellow circle within the circle, and that's the contrast going down through the channel of the vessel. So that's what we would call the lumen, or where the blood is flowing through. And all of the stuff surrounding that with the big circle is the wall of the blood vessel. So that is, which should be normally not a very big structure. It should only be just a little bit bigger than the channel, but all of this is then heaped up plaque in the vessel with some calcium around it. What it would look like with just the naked eye would be contrast here, which looks more of a bright gray color. And this area here, the computer has identified and drawn a circle around, is very low in density. It's less gray than the contrast, so it's kind of a more black color. If we go over to this middle panel here, we can see that that's more of a, I hope this is showing well up on your computer screens, but you've got contrast in the channel here, and then around that, you've got a more of a light gray scale here. And in the background tissue of the heart is more truly black. And as we go along, we can see little flecks of calcium in the vessel. This is a big chunk of calcium on the right-hand side here, and not much of the light gray stuff around it. And so Cleerly is a helpful tool to be able to characterize all this other stuff. The lumen is like the donut hole of the blood vessel. We're interested in what's going on in the donut. And the naked eye is reasonably good for being able to pick these things up. But with a Cleerly analysis, what we're able to do is use the X-ray density, which they call them these HU things there, which is a fancy name for Hounsfield units. It's able to tell us of these very low density things, which correspond to ugly types of plaque, if you like, plaque that is more prone to rupture or more prone to progress rapidly, versus things that have a higher Hounsfield unit density, which are more stable plaques that have had some time to become less aggressive, and it's plaque, but it's not a type of plaque that is likely to end the patient up in trouble. So keep this picture in mind. It's just, and again, it's a way of saying, look, hey, the computer is going to be able to identify through the miracles of artificial intelligence better than the human eyeball can how much of each type of plaque you're going to have. This is just some kind of in summarizing form there, what I've just been speaking about. High-risk plaques tend to be the ones that cause heart attack. They tend to be ones that progress rapidly. They don't seem to respond quite as well to medicine, and they cause symptoms. They cause even inadequate blood flow. And it's a continuum of risk. And we see, plaque stabilization, plaques trying to transition from here to here is a good thing generally, and medicines can help assist with that, like statin drugs and things. And low-risk plaques like this, which although there is quite a bit of calcium there, in this particular one section, there's not much plaque that would progress rapidly. So this one is not like, although calcium is indeed present at that particular area, it's not likely to be problematic. So if we've done a CT scan and we're doing it as a Cleerly study, what we'll do is we'll send it to them. The whole data set from the CT scanner gets uploaded to them. It gets analyzed by the computer, and a short time afterwards, we get back as the images, not just the ability to look at the scan on our own workstation, but we can use the Cleerly software to get a pretty detailed analysis of where the plaque is, what and how much of a plaque burden there is of each different type. And that's a pretty neat thing. And I just wanted to kind of go through a couple of different scenarios where different types of patients might have used these and what it did to help manage their care, because that's at the end of the day the other side of the coin too. It's not just about what do we do, what can we find with this technology, and what is it looking at, how does it do that. The other question is then, once you've accomplished this and you've got a Cleerly study done, what are you going to be able to do for that patient to get them out of trouble? So this one here is a patient scenario who in many ways is a lot like me, and having read this thing, I'm sort of, I guess, quite eager to get one of these done myself. A 44-year-old person who likes to go running, does marathons, has a very good marathon time, and has felt fine every time he's been out on the run, but just felt like he wanted to get himself checked out. He does take medicine for cholesterol. His cholesterol numbers really look pretty good on those medicines, but otherwise at face value, you would think this guy has got nothing to worry about. He's doing great running marathons. You would probably be inclined not to do much about him. But he had a Cleerly scan done and was found to have these are little pictures of his coronary arteries laid out. You would hope that his coronary arteries look nice and smooth and nice and gray all the way down, but you can see there's little flakes of calcium there. And importantly too, in these little panels here, you can see that the computer has identified something that the human eyeball may not be able to see very well, which is that there is plaque surrounding the vessel, and some of that plaque is quite high risk. So this particular person was found to have, quite a bit of high risk plaque, and despite having reasonably good quote unquote numbers, they decided to get very aggressive with his medications and put him on some newer cholesterol drugs that are injectable things called PCSK9 inhibitors. In a sense, it's like statins, but on steroids. They're injectable, so it's a really big deal drug to be on. But this is an intensive way of trying to really, really decrease the cholesterol and anything else that we can do to modify that person's risk. Theoretically, you could then potentially do this Cleerly scan down the road again sometime afterwards, sometime until you might say 2 or 3 years afterwards, and see if how much of that plaque has transitioned into more stable plaque. This is another scenario with a 53-year-old female who's a young mother. She has some symptoms, some shortness of breath, but nothing that's really super typical. And she actually had a calcium score done, which was 0. Calcium scores are a real sort of very basic version of this. They don't use any, because we're not injecting dye with a calcium score test. We are not, in fact, able to really characterize the blood vessel architecture at all, because you don't get to see the difference between the donut and the donut hole itself, where the contrast is running through. Anyway, this lady's blood work doesn't look all that remarkable, and she in fact actually had stress testing, which was normal, but she continued to have symptoms and ended up getting a coronary CTA done, which showed that indeed she doesn't have any calcified plaque, but what she does have was areas of low density, non-calcified plaque in her left anterior descending, and at one spot that was causing a 79% stenosis, and her doctor aggressively pursued medical therapies. And I guess I would say that, look, if you have having those symptoms and a 80% stenosis, perhaps that ought to be stented as well. I think I would be nervous about not stenting an artery that was 80% blocked, but you could argue about that point. But nonetheless, you have information that was not revealed by other testing and was not something you would necessarily expect. And we know that one of the things we do know about is that women oftentimes present with heart disease in ways that are less typical. They don't always have exactly the right quote unquote symptoms, or the ones that we read about in the textbooks. So we have to be fairly careful about symptoms, especially if they're exertional symptoms, to understand what they are. And shortness of breath is definitely a tricky one, because a lot of different problems can make you short of breath. And so trying to tease out what's what is hard. In a study like this, a CT scan combined with Cleerly seemed in her case to be very helpful. Here's another scenario of a man who was 62 years old, felt good, long time history of high cholesterol, but was really not super excited about taking statins because they had read about side effects. And gosh, we face this a lot. A lot of people are not super thrilled about taking long-term medications and concerned about all the side effects. So that's a common scenario. And indeed, if you look at his labs, his LDL cholesterol was very high, 182. So he wanted to know, what is he to do? So he had one of these done, and he also was found to have pretty significant plaque through his coronary system, some in the LAD. And they were able to see significant areas that were also of that low density type, low density non-calcified plaque, which is code for us to think, gosh, that's a high risk plaque that could transition into something more sinister. And so based on this was enough to help him be motivated to say, well, I've got to try and do something. So this was helpful enough for him to say, I'm going to start taking a statin after all, weighing up, which is important because here is somebody who's taking what might be good for some people. If you're just thinking about this as a high cholesterol problem and he feels fine, then that's a little bit more of a abstract discussion about cardiac risk. If you've got your imaging data in front of you and you can see, boy, there's all kinds of plaque in there, and this is now no longer about simply preventing disease but treating disease and trying to stabilize that which is there, that becomes a much more personalized discussion about what's really going on for that person. I think that's helpful. Here's a guy who's 54 years old and has had high cholesterol, and he had a previous CT scan that showed some non-calcified plaque, and he was instructed to get on about really trying to lose weight, change his diet, take a statin, and he followed through with that. He actually was able to lose a lot of weight. He really did what we asked him to, which we're thrilled when that happens. It doesn't always happen, sadly, sometimes, but sometimes life is tough and it's very difficult to make changes. But this guy wanted to get a Cleerly study done because having lowered his cholesterol with statins, having lost a lot of weight, he wanted to know what benefit had that been to him. And what he was able to demonstrate on doing the Cleerly more as a follow-up study is that a lot of the previously documented non-calcified plaque had turned into calcified plaque. And you would think to yourself, boy, I've increased my calcium in my arteries, that must be a bad thing. What we're learning more and more is that if the overall volume of plaque stays stable, but you transition from, so I think on this particular baseline study, his total plaque volume was 136. His actual plaque volume did diminish a little bit, and all of the non-calcified plaque, which was 105, most of that has gone away and largely now is represented by calcified plaque. So his calcified plaque has increased from 30 millimeters cubed to 40, so that's increased, but the high risk stuff, that went down. So it's kind of like, this is a helpful thing to know. If you've done a therapy and you've got some surrogates to say, hey, look, my numbers look better, you really want to also, it's kind of interesting to know, did that work? Are we okay with just the cholesterol medicine at the current doses, or do we need to intensify this further? And so he was able to demonstrate that, yes, indeed, his plaque burden not only diminished, which is great, you don't often see that, but it also changed in the morphology, the type of plaque that he had, to something that's going to be less severe. So that's starting to now get into the opposite side of the coin, which is to say, okay, doc, you got all this information, that looks real fancy schmancy, but what are you going to do about that to actually decrease risk? And it doesn't necessarily always have to be that that results in yet another test, another procedure. Many of these patients, we can demonstrate that this is happening through the result of medical therapies and lifestyle changes that the patient, because they have very personalized, specific information at hand, they're able to act on it with a great deal of motivation, and that helps them stay on track. And then I think this is the final vignette here, is a 45-year-old person who's been having funny tingling feeling in her chest. She thought it was stress related, having chest pain off and on. Cholesterol numbers don't look perfect either, but certainly none of us would fall off our chair saying that they're terrible. They're sort of elevated, but not terrible. And again, this lady had her coronary CTA done to kind of further evaluate, and she had quite a lot of both calcified and non-calcified plaque in her LAD. So, for a 45-year-old female, this would be pretty unexpected findings and concerning. And so she also has some low density non-calcified plaque. And some of that was 89%. And again, they say here that she wanted to initially try medical therapy, do a high dose statin and things like that. And she had resolution of symptoms. Again, I would sort of question whether letting somebody run around with an 86% blockage and nothing else other than medicines alone might be a little bit risky, because those can, 89%, 86% is not far away from 100. So I think stenting things can sometimes be important. Certainly it does illustrate that, you got onto the diagnosis and knew all about it, and with close, careful monitoring, medical therapies can certainly get somebody to feel better, and you can monitor their progress and see what's happening. But not knowing what's going on is definitely the worst problem to have. So anywho, that's kind of the, let me have a look and see what's in the chat here about people's different questions. Questions are, and these are going to be good questions here. One of them is, does Medicare pay for asymptomatic Cleerly treatment, testing, treatment, and meds as on the driver's case? So in the case of somebody who is, so Cleerly is not a covered benefit pretty much by anything at the moment because it's brand new. That would hopefully change as time goes along, as we continue to get more information that proves its worth, how much it really helps us to change things. Any treatment or any test has to come along and show that it's going to really be a novel thing, number one, and number two, that it actually is going to help identify patients much more accurately in such a way that you're changing outcomes. And I think it's going to do that. I think it's just going to take some time before that happens. So because it's brand new right now, it is not a covered benefit. It is a, when we send patients off to this, the patient has to understand, yep, they're going to have to pay out of pocket, potentially from flexible savings account or whatever it might be, but it's going to be an out-of-pocket cost for the study, and that goes directly to them, well, through us to them, and all of that. The CT part of it, because this is sort of a two-part test. Number one, you need the imaging is acquired through the CT. Now, the CT many times can be covered. It depends on what's going on. If it's being done to explore symptoms of chest pain, most of the insurances cover the CT portion of it, which at least helps to defray at least half of the cost of the test. And then the Cleerly test on top of that is a little bit more, but it's, arguably speaking, it's depending on your particular situation, that still might be, it's a value proposition, and you have to think to yourself, does the value of knowing that additional information, getting the full kind of detailed characterization of things, is that for this particular scenario that you're facing helpful enough that it's worth the money? There was another question in there. Do you need a PCP referral for the test? It does need a physician order, unlike a calcium score tests, which are the most sort of simple thing. I think those can be requested and done without a physician order. The CT scan, because it is a test involving contrast administration, does require a physician order, which can either come from primary care physician. We certainly have some PCPs around town that are requesting these, and are and that's fine. But our cardiologist will sometimes discuss that with patients, and if the patient wants to go ahead with one, order it from us as well. So if it's done as part of an evaluation for chest pain, and we sort of feel like this would be helpful, we'll sometimes put the order in. I will say there's probably, just to give you again there'll be a lot of questions about who's a good candidate for this too. You have to be a good candidate for a coronary CTA, where the CT is going to give you high value imaging and not be subject to a lot of artifact. And so the ideal patient for this might be somebody who has never been diagnosed with coronary disease before. They don't carry a diagnosis of that, but that's come into the picture as a potential concern, or they're worried that they might have that based on maybe some funny symptoms like we've seen in these cases that were there, plus various risk factors and things. If it's somebody who has long established coronary artery disease, there are probably patients with bypass history and multiple stents. Coronary CTA imaging of all that and Cleerly might not be very helpful. If it's maybe, it certainly can be done if with stents in place. It's one of the troubles when you've got a stent in the coronary artery is that it's sometimes difficult to see because the stent is a metallic structure. X-rays bounce off it and cause a lot of artifact. It's not easy to see what's going on inside of the stent, but every other part of the coronary artery will be well imaged. And so if your question is not so much what's going on in that little spot that's been stented, but what about all the other plaque that might be there, then it could be a very useful test still. So you have to have the imaging comes back much better if you're in a slow, regular heart rhythm. And things like that. So not everybody's a perfect candidate for a CT, and if you're not a good candidate for a CT, then the Cleerly sort of is a non-issue because it's not going to be done. But most candidates, I certainly would say, having said all those caveats, I would say that we are seeing a lot of good reasons to, instead of predominantly using stress tests to figure out patients with chest pain, that I think there's going to be a sea change to moving towards using CT scanning technology, CTA of the heart, to be almost our first line test for patients with, possible chest pain that might be from heart disease, because it picks up a lot more than just a stress test does in a lot of ways. Stress testing could certainly be helpful in some specific things, and we've used that as our basic primary test a lot of time. Another question there was, what would be the next steps if medical therapy doesn't resolve symptoms? I think, if somebody's having symptoms and they're, if they've had a Cleerly study that showed there's quite a lot of plaque there, I think the confirmatory test of this would always be a cardiac cath, where we actually go and take some pictures in the cath lab to see what's going on. And then sometimes if medicines alone are not enough to resolve the symptoms, sometimes stenting and bypass surgery and things are often needed depending on what the anatomy really shows. But so anyway, all right, I think that's kind of all I've seen so far for questions in the chat there. Mike, is there any other questions? Do we want to open it up for specific people to have a chance to ask questions here? Oh, sorry, I might have missed one here. It looks like there was a question about Watchman too. Does Cleerly coronary analysis how does that compare to the Watchman? That's interesting. So the Watchman procedure is another fascinating innovation that's come along. We often do CT scans on patients who are getting ready to have a Watchman implanted because we're looking at a particular part of the heart where the Watchman device would be implanted. And we often will get a look at the coronary arteries as well on the CT scan when we're looking at the heart in particular for that structure. But the Watchman is used for folks that have atrial fibrillation, and for whatever reason, they might not be a very good candidate to be on a long-term blood thinner. Maybe they've had gastrointestinal bleeding or something, and they need to have a Watchman put in. A Watchman is I guess my simple way of thinking about it and explaining it is it looks a little bit like an upside-down umbrella that goes into a little side pocket of the heart called the appendage, the left atrial appendage. And that happens to be where a lot of the clots form in folks that have AFib that can subsequently go and cause stroke. And so putting this little plug device into the appendage can block it off so that clots don't migrate from the heart to the brain. And so whenever the treating physician is looking at doing a Watchman procedure, they'll send the patient to us for a CT scan so that we can map that out a little bit. But that's it's a different part of the heart that we're looking at with that. It's looking specifically at a different structure. So Cleerly is more designed for folks to really look at their coronary arteries. And oftentimes folks with atrial fibrillation, their coronaries aren't well imaged. So, but if they happen to be in sinus rhythm when they're getting their study done, it might well be that they are well imaged, and potentially we could be getting a lot of good information about the coronaries on that if they are well visualized. But it's not a given that they will be, because irregular heartbeats make it difficult for the CT scanner to really see, get still frame motion-free images of the heart. It's a little bit like trying to take good quality pictures of children who are running around playing. You get no ways end up blurred. So, all right, well, that's kind of what we've got here. Any other questions at all? I know everyone's on mute at the moment. I'm not sure if we can, is there a way we can address any other questions for folks that might have them? All right, then, I think we are good. So thanks all for joining us today, and I think that's all we had for you. All right, stop sharing. No.